Hello everyone, welcome to Probably Nothing. As you can see from the lovely little strip down below, my name is Karen, but as I've started to say in more recent episodes, you know, for a laugh, please don't let that put you off. I am a nice Karen. The rumours are not true. It's not all Karens. Some of us are nice and want to talk about vaginas and gynae health and have a good old discussion about gynae queries. So welcome to Probably Nothing. It's the last episode 4 of series 5. How we've already done 5 series of this wonderful online platform, I do not know, but here we are. The end of series 5. Thank you so much to everybody who either tuned in live to episodes 1, 2 and 3 or indeed caught up afterwards. We're live now for half an hour until 6:30, but we will put up the recorded version thanks to the wonderful Disruptive Media who do all of this for free for us, and Probably Nothing wouldn't exist without them. This sounds like a sort of Oscar speech, doesn't it? But yes, we'll put up everything afterwards, so if you can't watch live, no problem at all. So episode 1 of series 5, we had lovely Claire talking about vulval cancer, signs, symptoms, advocacy, support, etc. Episode 2, we had wonderful Claudia from Survivors Trust talking about accessing cervical screening if you are a survivor of sexual trauma. Episode 3 was last week, and we had Dr Philippa Kay talking about menopause and managing early menopause as a result of gynae cancer treatment. And that was Athena Lamnasos, our CEO, that steered that ship last week, because it doesn't look like it, but I was on holiday in Portugal last week, so I know I've got nothing to show for it. But I am back, and I run the Ask Eve service with our amazing nurses Tracy and Hilary. And we started Probably Nothing almost a year and a half ago now, because we were getting lots of people coming to us saying, you know, sorry to disturb you, it's probably nothing, but, and then they would ask their gynae concern. And the good thing, in a way, I guess, is that most of the time gynae cancer, potential gynae cancer symptoms aren't gynae cancer. All of the symptoms for all of the 5 gynae cancers are much more likely to be something less serious than gynae cancer. But for 58 women and people a day, it is a gynecological cancer diagnosis. So it's our job to talk about various different topics, vulval cancer, cervical screening, menopause, etc., in a hopefully informative, kind of informative and informal way, accessible, so we can ask experts each time. I have a guest on for each episode talking about your questions relating to that particular topic. So also, lovely Ben, who is backstage from Disruptive, said, you'll do a nice quick intro, won't you? And I said yes, and I think I was lying. So I'm sorry. I've done it again, and I don't think I'll ever break this habit of rambling until the cows come home. But, okay, so this episode, so at the end of series 4, we had a fantastic episode with Dr Anne Connolly, an amazing GP, and it was kind of a sort of GP drop-in session where it wasn't on a particular gynae topic. It was just anything and everything that you want to ask. GP drop-in clinic, let's go. And it was great. We reached so many thousands of people. I don't think it was just my mum watching the episode over and over again because she's so proud. And it was really, really fantastic. It reached so many people, answered so many different questions. So we thought, let's end series 5 in exactly the same way. So Anne, come to me. Well, it sounds like she's in the same room on the same screen. There is a difference. So this is the lovely Dr Anne Connolly, who has worked with us for a little while now, and Anne is a GP based up in the north, up in Bradford, and specialises in gynecological and sexual health. So hello Anne, can you give a brief introduction to yourself and your interests that's maybe like slightly quicker than what I just did?
Hi Karen, thanks so much for asking me back. Yeah, so I'm a GP up in Bradford. I've worked in Bradford for more years than I'm going to tell you, and I've done lots of work in the hospital. I worked in the colposcopy clinic, you know, that's where you go after you've had your smear problem, and I worked in the hysteroscopy clinic for many years. That's where you go if you've had your bleeding problems with cameras and things, and I worked in the sexual health clinic for years, as well as doing my GP. So yeah, go for it. Let's just talk through some of the issues, and we'll just discuss whatever we can.
we'll just crack on. Okay, so we've got a list of questions for people that watch. We've got a list of questions, but also if you're watching at whatever platform you're watching on, you can ask a question as we're talking, because Ben's backstage for Disruptive, and we've also got backstage Lydia, our wonderful comms manager at Eve, who will be fielding questions to us if they come in. So ask whatever you want, gynae, health-wise, pop it in the box and we will get to it if we can, and I'm almost certain we will, because we'll try our absolute best. So let's just dive straight in. Okay, Anne, bleeding and pain during sex. When and how to bring this up with my GP?
Okay, so yeah, common. The point is about sexual health or women's health issues. If it matters, it matters. It is probably not nothing. So although it's probably nothing, it's not nothing to you. So if you're worried about it, then discuss it. You know, we as GPs, we hear all sorts, and we listen to all sorts of traumas, stories. You know, that's our job. That's what we're there for. And if you've got a problem, then bring it to us and ask us about it. In the moment, you'll probably have to do it over the phone, which some people find easier because, you know, you're not face to face, and you can be a little bit more, feel a little bit more, you know, not embarrassed over the phone maybe. But write down your issues, write it down, and so you've got the words there, so you don't have to be thinking about how you're going to phrase it. You know, practice beforehand. But if it's bleeding, what I want to know is, so when is that bleeding? Is it happening every time? How long has it been going on for? How much is it? And the pain, you know, how is the pain sort of a grating pain, like a vaginal pain, like a rawness, or is it a deep pain right inside? Because they give me some sort of idea about what it is I might be needing to do and examine you. But then with bleeding and pain after sex, I'm going to be wanting to bring you in. I'm going to be wanting to have a look, which will be an examination. You can ask for somebody to come with you if that makes it easier for you. You know, we pull the curtain around so that that friend or whoever doesn't have to see what's going on, but they can be in the room with you if that's what you want. You can ask to have a chaperone, and most of us would offer a chaperone if that's what you want. And our chaperones are all trained. You know, so do it. Don't put it off, because sometimes, usually it'd be nothing. Sometimes it might be an infection like thrush, which is a not sexually transmitted infection. It's just there. Sometimes we'll want to do a smear or refer you to have somebody look at your cervix with one of these magnifying systems, the colposcope. Sometimes it will be to do with other reasons like gynae stuff, like endometriosis. And sometimes it will be due to sexually transmitted infections, and we'll want to do the right tests, and you know, the sooner you get it sorted, the better.
And you said at the beginning, when I first asked the question, you know, you said common. Is it very common for someone? So if somebody suddenly has sex tonight, yay, good for you, and they get and it's vaginal penetration, and they feel some pain and get a bit of blood, it's not the most uncommon thing in the world, is it?
No, and if it was a one-off, you know, you could probably ignore it. It's just if it happens, because sometimes you know, things are a little bit more adventurous in sex, and you know, sometimes if it's the first time for sex for a while, you know, there are reasons sometimes why it happens. But there are also more serious reasons. Pelvic infection, so sexually transmitted infection, something with the cervix. Usually that's nothing. Normally it's to do with your pill, or it might be a local inflammation. It might have been there for a long time due to our hormone changes, but it might be something more serious. So don't ignore it. One-off maybe, but if it happens more and more frequently than that, don't think, oh, she said it was all right to ignore a few. No, I'm not saying that. I'm saying maybe one, but if it happens again, then just someone will look. And I know the press say we're not open. We are open. We are doing face-to-face. We might be triaging over the phone, and that's to keep everybody safe. But we are open, and this is one of the things we don't say, actually, that's okay. And we certainly don't say send a photo in.
And just quickly, because I know people watching are probably thinking it, and we've definitely to the Ask Eve service had loads of questions like this, kind of more sort of appointment based rather than symptom based. Like, say I had bleeding after sex tonight, phone my GP in the morning, and they say, and I say, oh, Dr Anne's my GP, can I see her or talk to her because I've got bleeding after sex? Lots of people are told, oh, I have to wait, you know, at least 2 or 3 weeks for an appointment. Is that always the case, or is it like, depending on what the problem is, you might be able to call me back sooner than the 3-week appointment I've booked in with the receptionist?
So most people are doing a triage so that you will get put in for a phone call either that day or the next day. It's the physical appointments that might be taking a bit longer, because that allows me to think, well, actually, yeah, I really need to see Karen today. Whereas something else, I might think, well, you know, I'm really full today, but I've got an appointment next week, you know, pain in my little finger. It's not due to trauma. It's been there for a long time. Okay, well, let me think about seeing that next week. So, or 2 weeks time or 3 weeks time. You know, we're trying to manage that workflow. So we do urgent things today. Less urgent things can wait a little bit. And unfortunately, some of them will have to wait a lot longer at the moment.
Thank you, Anne. Okay, question 2. Should you tell a new partner you have HPV?
Oh, these are great questions. HPV, we've pretty much all had HPV at some point. We don't know about it. You only know about HPV when you've had that smear, and what, you get them every 3 years, 5 years. So, you know, you got HPV on that day. And lots of us have had HPV in the past, but the swabs didn't, you know, the smears didn't pick it up. So no, I wouldn't. It's one of these things, you know, your partners may well have HPV, but you know, if it's a man, we're not testing them. If it's another female, she may or may not have had that smear done recently, so she knows. You know, but we all pretty much get it. The youngsters who are coming through now, I think probably the eldest ones who had the jabs were probably about 29, 30 now. And we know that HPV rates have gone right down in that age group. And now we're doing the boys as well. It's going to make a real difference. So HPV is pretty normal. Well, it is, you know, not even from penetrative sex, you know, it's from coming into contact. So let's not blow out of proportion. It's not like chlamydia. It's not like gonorrhea. It's not like the STIs. It's just a normal infection that most of us get at some point and then get an immunity to.
And is it kind of fair to say that, say I had chlamydia, I would need to have treatment for it, but with HPV, you can't treat it. You can treat things that HPV causes, like abnormal cervical cells that are found, but you can't, if we're just sat here with HPV, we can't do anything about it, can we? We can't take a tablet to get rid of it.
No, exactly. So HPV, it's a virus. Like all viruses, we get an immunity to it. So when you get a cold, your GP says you've got a cold, or your pharmacist says you've got a cold, you will get an immunity to it at some point. And that might take 2 days, 3 days, 4 days, dependent. With HPV, you can't say, well, it'll take 1 month, 5 months, whatever. We just know that at some point, the majority of women will get an immunity to it. And those who haven't, who have HPV, they will be monitored, particularly for cervical cancer, because that is the most important one. They will be monitored until they either get their own immunity and reverse the problem, or they get to a stage where they might need some treatment to get rid of it.
And HPV, so if people are like, what's that? Human papillomavirus, a group of viruses. There's over 150 different strands. About 13 are high risk, so can cause some types of cancer, like cervical that Anne was mentioning. And then there are lower risk types that cause things that are less serious, but nonetheless, you know, need looking after, like genital warts, for example. But Anne, so people, you can't take a tablet to get rid of it, but can you just talk a bit about smoking? If people are smoking and you see that they come back to you time and time again, they've got HPV, it's not going away, but they're smokers, what are you going to tell them?
Well, you know, smoking, we talk about smoking all the time for so many health habits, don't we? So cardiovascular disease, you know, all those cancers, and certainly smoking is not great for HPV. It's not great for some of the other cancers, gynae cancers. So if you are a smoker, then it's another reason to go and talk to your local smoking cessation service about getting some help. And there's so many products out there now that maybe the patches won't sort you, the gum might not sort you, a spray might, you know, there's lots of different personalized approaches to it. So do think about giving up your fags.
And just kind of wrapping up that question, it's, you know, as you said, it's not just penetrative sex that HPV can be passed on by, it's any type of sexual contact. And it doesn't mean that, say I didn't have HPV in my last cervical screening, then had sex with someone, and then the next time I had cervical screening had HPV, it doesn't mean that that man Tom is to blame for my result, does it? You can't pin it on a person like you can if you suddenly get warts or something.
No, exactly. So and lots of, we're only just getting into the stage of having done HPV tests. So, you know, somebody who's having a 5-year test, they won't have had a test for HPV on their previous one. 3 years would adjust. So, but you know, there's so many good resources out there, and you've got some really good resources on HPV. So if you want,
I didn't want to plug our own resource.
I will, because they're so good.
I was like gearing up. I was like, I hope she mentions it. Yeah, we've got a guide all about HPV. There's information out there, and we want to talk to people about it. Yeah,
get rid of some of these myths, because it is putting people off coming. It is making people angry. I was in colposcopy. I don't know if I told this story last time. I was in colposcopy, and a woman who was told she had HPV on a smear, she threw, before she came back to colposcopy, she threw her husband out, because she said, he's the only person I've had sex with, and my last smear I didn't have HPV on. And of course, when we looked at the results, she'd got this other word on it that says viral changes, but in the old days we didn't call it that. We called it something else. So I said, look, this is the report, this shows you had it then. And she looked at me in horror and said, I guess I ought to go and apologize to him. And I said,
gosh, it can have a massive impact, can't it? Yeah, it's just because you, so should you tell a new partner if you want to, but you don't have to. It's not like something like chlamydia, or you know, if somebody is HIV positive, it's not, and you know, it's not undetectable. It's not like that. It's common. You can't trace it to one person. Over 80% of us that have had any type of sexual touching and fun will get it at some point. Most of the time it will clear. It's not, you've not done anything wrong, and you don't have this massive weight on your shoulders if you have HPV.
Exactly.
Thank you. Okay, so slightly leading on from that, not a dissimilar question. So I've just been diagnosed with cervical cancer, but don't feel I can talk to my family, as they will assume I've been sleeping around. We're Nigerian and religious, for context. It's difficult, isn't it?
Really tough, tough, because there are, HPV is the cause of or some of the strains of HPV are the cause of the majority of cervical cancers. But, you know, it's more around how you're dealing with that one episode of, it may just been one episode of sex, one partner. But you, for some reason, haven't managed to clear the HPV infection from your own system as you would have liked to have done. But it certainly doesn't mean you're promiscuous. It certainly doesn't mean that you've done anything wrong. And again, have a look at those resources on the Eve Appeal. Share them with your family if that would help. But that's a really, you know, that I feel sorry, and I'm sorry that you can't feel that you can talk to your family, because it's important too, because they actually would want to talk to you. They would want to be there for you, but they just need to be educated if you want.
Thank you, Anne. Okay, I've noticed some small bumps on my vulva, but I'm embarrassed to tell anyone about it. What can I do?
Okay, small bumps on the vulva are usually due to like little fatty lumps. So they're usually, you know, like you can get little cysts anywhere in your body. You can get them where we've got hair, and you've got hair down there in that part. So that's what they normally are. If they are painless. They're not itching. You've got a few of them. Look with a mirror, and if they are sort of a smooth yellow and you think, oh, that looks like a zit, I could have had that anywhere, then you could just say that's okay. But if you've got any worries at all, then get somebody to look at them. Your GP can, the sexual health clinics, they will look at them. If you prefer to go to a sexual health clinic, if you're there at a smear, or there for some other reason with your nurse could have a look at it. Just they are probably nothing. But if you've got any concerns, and the things to worry about are if it's persistently itchy, if it bleeds, if it's sore, if it's increasing in size, if you've got one, they are the sort of things that you should be slightly more concerned about. But if reassurance is great, so go and make an appointment.
And I think a lot of the time, especially during COVID, and I was about to say the old school 2020 phrase of unprecedented times, but I caught myself. But people are really, I don't know if you experience this once they actually get to you, but they're kind of worried about and stressed about bothering their GP with something that is like a few bumps on your vulva is less likely to be vulval cancer than if someone finds a lump in their breast, because it's a much less common disease and things like that. Is that fair? So people worry that they say, we've had people say to us, it's I know it's not common, but I'm really worried. And it's kind of about, I want them to know that it's just as important as if someone felt it in their boob, Exactly.
If it's there, if it's a lump, if it's worrying you, it takes me, a couple of minutes to have a quick look and go, yeah, that's what this is, and, reassure and whatever. So, we're open, we're back working, and the concerns you've got about these issues, can I tell you, will not be less important than the concerns that lots of other people are coming back in. Okay, 6 months ago, a year ago, it was very much, let's keep away from you. I can promise you now it's not now.
Yeah, of course. Is it normal to have a yellowish discharge? Yellowish.
Okay, so most women who are still having periods will have some discharge. And so most women will find that they have their period, and then mid-cycle they have more discharge, and then before the next period it reduces, and then you have your period. So that's the natural thing that you see. Some people who use the combined hormonal contraception, so the combined pill, so that's the one with the two hormones in, they will find that makes them get more discharge. But sometimes there are infections that will cause discharge. So if it's itchy, then it might well be thrush. So you could go and get something from the chemist. If it's yellowish and it's smelly, particularly if it's smelly after sex, then it might be something called bacterial vaginosis, which is, again, it's a non-sexually transmitted infection, but is something that is very common. And again, you could talk to your pharmacist or your GP. If, however, you've had a change in partner, or you've got any other issues like bleeding after sex, bleeding between your periods, then you would need to go and see somebody, because you'd need a chlamydia swab to start with. That causes a discharge. Gonorrhea swab, less frequent, but again can cause discharge. Or you may have a problem with your cervix. So yes, it's normal, but if it's changed and it's persistently changed, or you've had any sexual health risk, then go and get the swabs done. And these days, we would look, if you were bleeding, we'd have a look. But if it's just you've got a concern, we'd probably just give you a swab to do yourself, and that picks up chlamydia or gonorrhea.
And if it is chlamydia or gonorrhea, is that easily treated? Is it kind of this long journey that someone has to embark on to get rid of it? How is that?
So chlamydia is very common, very straightforward. The majority of women who have chlamydia don't actually know they've got it. Half of men who have chlamydia don't know they've got it. And that's why we should routinely go for tests, especially when you change partners. And if you're asymptomatic, so you've not got symptoms, you'll get given a bit of cotton wool, a bit like the thing we've been sticking up our noses, and you just stick it in your vagina. Give it, in Yorkshire, we say, give it a good mooch around, and that will tell you whether you've got chlamydia or gonorrhea. And for men, forget the umbrellas. We've got over the umbrellas. We can now just get them to pee in a pot. And again, that is equally as good. So chlamydia, very common. are very easy to treat. You take some antibiotics. The biggest issue is you then have to make sure that the person you've had sex with is also treated, or else you just pass it backwards and forwards. Gonorrhea is less common, but it is more complex to treat. So if they come up with a gonorrhea swab, then they'll be recommended to go to the sexual health clinic, because they need to do sensitivities and they need to make sure you get the right antibiotics, and also that the partners, that's really important, that partners are treated. But the tests are so straightforward. So if you've got any risk, change your risk, just go and get a chlamydia swab. You can often get them, look on your local sexual health network website. You can often get them by post these days, so you don't even have to go anywhere. You can just log online, get a self-test sent to your house, do your own swab, off you go, result, bang, sorted.
Thank you, Anne. Also, I love that we're talking about STIs and you said bang. Look, bang, sorted. It's perfect. Perfect. That was a beautiful, beautiful little moment. Going back slightly to kind of vulval changes. So someone says it's a longer question, so I'll kind of abbreviate. But my GP thinks I've got lichen planus. So in a sec, let's explain what that is first. I've been referred for a gynae appointment, but it could be up to a year before I get this appointment. I've seen that if you have a lump, ulcer and bleeding, you're more likely to go on a 2-week wait for suspected vulval cancer. I don't have a lump, but I've got the ulcers and bleeding. I'm a 35-year-old mum of 3. I can't afford to go private. So ulcers and bleeding, suspected lichen planus, referred, but up to a year's wait. What do we do?
Well, lichen planus is really sore. So I feel really sorry that you've got to think of a year of sitting with lichen planus, because it can be terribly sore.
What is LP, as we say in the biz?
Okay. So lichen planus is a autoimmune inflammatory response to the skin of the vagina. So it can cause soreness, it can cause ulcers, it can cause bleeding, it can cause problems with pain when you pass urine, because it just goes over this raw area. It's a bit like having nappy rash all the time. So I'm surprised they're talking about a year. Often there's a vulval dermatology service, so it might be worth asking for a referral to your dermatology clinic, seeing if that's any better, or even thinking of registering with a local GP practice that might have a dermatology expert. You know, on our website, we put what our specialties are. So if you come to my practice, then you'll know I'll be doing the women's health, and someone else will be doing the long-term diabetes. Someone else will be doing the kids. So you could look and see if there's another GP practice that might take you on, which has got a dermatology expert. But otherwise, basically, it's the same with lichen sclerosis, which is another skin condition, but that's not nearly so painful. It's about soap avoidance, so using water to wash with, using a non-biological washing powder, do not sit in bubble bath, etc., etc. Using lots of emollient, so that's like E45, aqueous cream, any emollient you can get hold, any gunk you can get hold of. And then it's about using a steroid cream, but then that needs to be given to you and watched. But at least do the emollient and the soap avoidance, at least to start with. But I think I would be going back and saying, actually, this isn't okay, because it is not okay. And you know, if nothing else, go and say, and now I've got a lump and I've got an ulcer, and they might send you through a bit quicker.
Would you, based on what I just said, would you be worried that, because it's suspected lichen planus, would you be worried that this is in fact a cancer, or is it more just that it probably is lichen, but it's just awful to have to deal with for a year without knowing?
Yeah. So a vulval cancer, they're very rare in young women, and normally it starts from a small area. It'll be an ulcerated area. Which would bleed and would be very itchy, and can often be very itchy, whereas lichen planus is more of it affects more of the area and may go up into the groins. You may even get sort of a skin rash, a blistered skin rash on here or in your mouth. So it's more of a generalized skin condition, in which case why a dermatology person might actually be better for you.
Thank you, Anne. Okay, last question, which is timed very nicely, is, okay, so I'm 43. I've gone through early menopause due to breast cancer. What are my options with HRT, as women in my family have horrendous menopause and are refused HRT on breast cancer grounds? Is estrogen gel an option, for example?
Okay, this is a complex question, isn't it? So it really depends on what your breast cancer was like, what the sensitivities, what hormones it was sensitive to, what sort of treatment you've had, whether it affected any other part, whether it's likely to be absolutely clear. So there's lots of different factors in play. Because you've had one breast cancer, or you've got a strong family history of breast cancer, you know, you may get a recurrence, or you may get another, or you know, there are other things that might be more concerning. So HRT does slightly increase. It does slightly increase. It does increase getting breast cancer, but it's not so much. But it does increase in families who've already got it, as opposed to the women who haven't had it or haven't got a strong family history. It doesn't exponentially take you off like that, but it takes you off on an increased curve. So it's a conversation with your oncologist. It's a conversation with a menopause specialist. A GP wouldn't be putting you on HRT. And estrogen gel is no safer on the breast really than any of the others. So that's someone clever needs to talk to you about that. But it may not be that it's a no. You know, some women, you take the risk, you get the information, you decide, actually, my life's so miserable, so let me think I might take that. But you've got to know the information. You've got to be able to make the choice yourself.
Yeah, we do hear from people that are at an increased risk for whatever reason, but because are struggling so much with the symptoms of menopause, it's the slight increased risk is worth alleviating the symptoms for however many years. You know, it's about individual care, isn't it?
It is. But also, don't forget, from HRT point of view, that from a breast cancer point of view, our weight and sadly our alcohol intake are more risky than HRT on our breasts. So, you know, there are other lifestyle, and smoking. So there are other lifestyle factors that we can also be addressing.
Thank you, Anne. That is the end of the episode. We've timed that very well. Sometimes I ramble on for hours on end, but I think we've that was kind of compact. We smashed it, Anne. Is there anything, before I say thank you and goodbye to you and put you backstage, is there anything you kind of like, any takeaway messages for people that are watching, or, you know, like top line, pow?
Don't put it off. You know, if you've got issues, lots of people have put stuff off because of COVID.
Have you seen that?
I have. In the gynae clinic, I certainly saw someone with an advanced endometrial cancer, womb cancer, because she'd been shielding and she wouldn't come. So if you've got symptoms, if you've got concerns, we are open. Whatever the press say, we are open. We will listen to you. Write down your notes so you don't get embarrassed. Just say it as it is. And if you don't get the answer the first time, then make another appointment, go and talk to somebody else. But, you know, it is probably nothing, but it might not be.
Thank you, Anne. Thank you. Go and wait backstage and I'll say goodbye to you in a sec. Thank you, Anne. That was Dr. Anne Connolly, everyone. Thank you so much for everybody that's tuned in and watched our live GP drop-in session for the last episode of Series 5 of Probably Nothing. The wonderful Disruptive and our Lydia will work together and put it up on our channels, so you can catch up whenever you want. You don't have to have watched it live. That's fine. Everybody's different. I've got a ring light behind my laptop, which is why I look ghostly and you can't see my tan from Portugal, and my cat has just made an appearance in the ring light, so that's my evening sorted. Thank you so much for watching. And if you've got any questions about any kind of gynae health, gynae cancer concerns, then Ask Eve, the service that I run, as well as Probably Nothing, is always open to talk to people, regardless of whether there's, you know, a series of Probably Nothing going on. And we are available on nurse@eveappeal.org.uk, and yeah, you can ask us any type of gynae query. Nothing is too big, small or trivial, and we'll always do our best to help you. So thank you again so much for watching. We'll see you soon, and stay safe.